This conference will now be recorded.
All right, so we're going to talk about airway tonight. We covered a little bit of this stuff with assessments last week, but we're going to go a little more in depth with airway-specific stuff tonight. So, the single most important step in caring for a patient is to address their life threats. A primary component of that step is ensuring that they can breathe adequately. When the ability to breathe is disrupted, oxygen delivery to the tissues and the cells becomes compromised. Oxygen will reach the body tissues and cells through two separate but related processes, breathing and circulation. So we got a little picture here with the anatomy of the respiratory system. So as you can see, we start at the top with the nasopharynx. Then we have the nasal passage, the pharynx, the oropharynx, the mouth, the epiglottis, and the larynx. So those items together are the upper airway. For the lower airway, we start out with the trachea, the bronchioles, the main bronchus. The apex of the lungs is the top of the lungs. The carina is the dividing point in the middle. The base of the lungs would be the bottom. And you can see your diaphragm underneath the lungs. The respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. The airway is divided into the upper and lower, as we just saw in that diagram. Some of the anatomy components, we just went over them: the nose, the mouth, the oral cavity, the pharynx, and the larynx. The main function of the upper airway is to warm, filter, and humidify the air as it's entering the body. The pharynx is a muscular tube extending from the nose and mouth to the level of the esophagus and trachea. It's composed from top to bottom of the nasopharynx, oropharynx, and laryngopharynx. So here's a little diagram of your pharynx. At the top, you can see your nasopharynx. In the middle, your oropharynx. And at the bottom, you've got your laryngopharynx. The nasopharynx, its primary job is to filter out dust and small particles. It also warms and humidifies the air as it's entering your body. It's lined with a mucous membrane that actually filters out that dust and any small particles like that. So the oropharynx, it's the posterior portion of the oral cavity. The epiglottis is superior to the larynx, and that epiglottis helps prevent food and liquid from entering the larynx during swallowing. Imagine a little flap that goes over your throat to close it off. And here you've got a nice diagram. You can see the mouth with the uvula, the tongue, and then on the right-hand side, you can see you've got your nasal cavity, your upper lip, tongue, hard palate, soft palate, entrance to the auditory tube, or the ear canal, the nasopharynx, the uvula, which is what hangs in the back of your throat there, the oropharynx, the epiglottis, which is that little flap, and the laryngopharynx. So here's the larynx. The larynx is a complex structure formed by many independent cartilaginous structures. That's a fun word. Made of cartilage is effectively what they're getting at there. It marks where the upper airway ends and the lower airway begins. So this is your dividing point. You can see you've got your thyroid cartilage, your cricoid membrane. So right in that area is where your Adam's apple lies. The trachea is down at the very bottom. The thyroid cartilage forms a V shape anteriorly, known as the Adam's apple. The cricoid cartilage, or the cricoid ring, is the first ring of the trachea. The cricothyroid membrane is the elastic tissue that connects the thyroid superiorly to the cricoid ring inferiorly. The glottis, or the glottic opening, is the area between the vocal cords. It's the narrowest part of an adult's airway. Your vocal cords are white bands of thin muscle tissue. They're partially separated at rest, and they help you produce your speech. They also protect the trachea from the entry of substances like water and vomit. The anatomy of the lower airway. So the primary function of the lower airway is to deliver the oxygen to the alveoli. And your lower airway includes your trachea, your bronchi, and your lungs. The trachea, it's a conduit for air entry into the lungs. It begins directly below your cricoid cartilage. It descends down the midline of the neck into the thoracic cavity. In the thoracic cavity, the trachea divides at the carina into the two main stem bronchi, right and left. So the carina is that middle point. The bronchi are supported by cartilage, and they distribute oxygen to the two lungs. Upon entering the lungs, each bronchus divides into ever smaller bronchi, which then divide into bronchioles. So again, here's your diagram. Trachea is your windpipe at the top. The carina is the middle point. The alveoli are the little tiny parts at the very end. You've got your main bronchi, your smaller bronchi, and then your bronchioles at the bottom. So bronchioles are made of smooth muscle. They dilate and constrict as the oxygen passes through them. The smaller bronchioles connect to your alveoli. The alveoli is the site where your oxygen and carbon dioxide, that actual gas exchange, occur. They're formed of millions of thin-walled, balloon-like little sacs. The alveoli are surrounded by blood vessels or pulmonary capillaries, and oxygen diffuses across the alveolar membrane into the pulmonary capillaries. Oxygen that's in the pulmonary capillaries is transported back to the heart, and then it's distributed out to the rest of the body. Carbon dioxide diffuses from the pulmonary capillaries into the alveoli, where it's then exhaled and removed from the body. Some more anatomy here. You can see your trachea, your vena cava, your aorta, your heart, the diaphragm, your bronchus, and your lungs. The heart and the great vessels are present in the thoracic cavity, and they're very important for your respiration. The great vessels are the vena cava and the aorta. So the mediastinum is the area that's between your two lungs. In that area, you have your heart, the great vessels, the esophagus, your trachea, your major bronchi, and a whole bunch of nerves. The phrenic nerve is found in the thorax, and the phrenic nerve is what actually allows your diaphragm to contract, which is necessary during your breathing. The physiology of your breathing. The respiratory and the cardiovascular system have to work together. They ensure that a constant supply of oxygen and nutrients is delivered to all of the cells of the body. They also remove carbon dioxide and waste products from your cells. And we kind of touched on this last week as well. So ventilation is the physical act of moving the air in and out of the lungs. Oxygenation is the process of loading the oxygen molecules onto the hemoglobin molecules in the bloodstream. And then respiration is your gas exchange. That's where the actual oxygen and carbon dioxide are manipulating in the alveoli. It's important to know the difference between the three of these. Again, ventilation is the physical act of moving the air in and out of the lungs. Inhalation is the active muscular part of the breathing. The diaphragm and your intercostal muscles contract, which generates the negative pressure in your thorax, allowing the air to enter. The lungs require that your chest moves and all the supporting structures also expand. Partial pressure is the amount of gas in the air or dissolved in the blood. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and the blood are equal. Deoxygenated arterial blood that comes from the heart, the partial pressure of the oxygen is much lower than the partial pressure of the carbon dioxide in the pulmonary capillaries. Your body is working to equalize that partial pressure, which results in the oxygen diffusion across the membranes into the blood.
One subject, wrist, sternum, and back injury, seconds.
So if you look at the diagram on the right, it almost looks like deflated balloons. And if you imagine the mechanism of ventilation, it's like the balloons inflating and then deflating. When the lungs do that, the diaphragm and all the structures around the lungs have to move along with that. So your inspiration delivers the oxygen to the alveoli. Not all of the air that you breathe in is going to reach the alveoli for the gas exchange. Tidal volume is the measurement of the depth of your breathing. The average adult, the tidal volume is somewhere around 500 mLs. And then your dead space is the portion of the air that doesn't reach the alveoli. So exhalation. This does not require muscular effort. It's a passive process. The diaphragm and the intercostal muscles will relax, which decreases the size of the thorax. The smaller thorax compresses the air into the lungs into a smaller space. The air pressure in the thorax is higher than the outside pressure, which pushes the air out through the trachea. So to recap, inhalation is an active process. You have to actually suck the air in. Exhaling, the chest gets smaller, which pushes the air out on its own. It's not an active process. The regulation of your ventilation involves a complex series of receptors and feedback loops that can sense the different gas concentrations in your body, which then sends messages to the respiratory center in the brain to adjust the rate and depth of your ventilation. Your body's need for oxygen constantly changes, and failure to meet the need could result in hypoxia, which is a condition in which the tissues and cells of the body don't get enough oxygen. Hypoxic patients can die quickly. Your body has something called hypoxic drive, which differs from the primary control of breathing, where it uses the levels of oxygen in your blood to control your breathing. That's typically something you'd see in a patient that has end-stage COPD. Some people believe that administering high levels of oxygen will increase the amount of oxygen dissolved in the plasma, which would then negatively affect the body's drive to breathe. So patients that have things like COPD, throwing a whole bunch of oxygen at them when they're having trouble breathing can actually negatively affect them. Overloading them with oxygen is not necessarily a good thing. So oxygenation is, again, the process of loading the oxygen molecules onto the hemoglobin molecules in the bloodstream. It's required for the internal respiration to take place, and oxygenation does not guarantee that internal respiration is taking place. Ventilation without oxygenation can occur in places where oxygen levels in the breathing air have been depleted, such as a mine, a confined space, high altitude, a fire. So in that scenario, you're still moving air in and out, but the concentration of the room air does not actually contain enough oxygen to oxygenate the body. And then your respiration. This is the actual exchange of the gases, the oxygen and the carbon dioxide, in the alveoli and in the tissues of the body. Your cells take energy from nutrients through a series of chemical processes known as metabolism or cellular respiration. Each cell combines nutrients and oxygen, providing energy and waste products. The waste products are typically water and carbon dioxide. External respiration or pulmonary respiration is the process of breathing fresh air into the respiratory system to exchange the oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. Surfactant reduces the surface tension with the alveoli, keeps them expanded, which makes it easier for the gas exchange to occur. Surfactant is effectively the lubricant in your lungs to keep them moving smoothly and to prevent some of that friction between the two. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. Oxygen passes from blood in the capillaries out to the tissue cells. Carbon dioxide and cell waste will pass from the cells in the capillaries, where they're then transported via the venous system back to the lungs. All of your cells need a constant supply of oxygen to survive, and when there's adequate oxygen, cells will convert your glucose into energy through aerobic metabolism. Without adequate oxygen, anaerobic metabolism takes place, which cannot meet the metabolic demands of the cell. So aerobic metabolism occurs when there's adequate oxygen. Anaerobic metabolism takes place when there's not enough oxygen in the atmosphere. Factors in your nervous system. Chemoreceptors monitor the levels of oxygen, carbon dioxide, hydrogen ions, and the pH of your cerebrospinal fluid and provide feedback to the respiratory centers. So your body has all these mechanisms of monitoring the level of oxygen, the level of carbon dioxide, the hydrogen ions, and the pH of your body. And that's what drives your respiratory system. When serum carbon dioxide or hydrogen ion levels increase, the chemoreceptors will stimulate the medulla, the part of your brain, to increase the respiratory rate. Stimulation from the pons will affect the rate and depth of respiration. So these receptors in your body are sending signals to your brain to control the rate and depth of your breathing. Ventilation to perfusion ratio and mismatch. Ventilation and perfusion must be directed to the same place at the same time. Failure to match your ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. Your body is always striving for something called homeostasis, which is the normal level. Your body's always striving for things to be normal, for things to be in sync. And that's what they're talking about here, the ventilation and perfusion ratio. When ventilation is compromised but perfusion continues, the blood will pass over some of the alveolar membranes without gas exchange taking place. This results in a lack of oxygen diffusing across the membrane and into the blood circulation. Carbon dioxide is not able to diffuse across the membrane into the lungs and therefore recirculates within the bloodstream. When perfusion across the alveolar membrane is disrupted, optimal exchange of gas is prevented. So when your ventilation and your perfusion are not matching, when it's not at homeostasis, when it's not at its norm, the gas exchange isn't going to happen correctly. You end up with a lack of oxygen and an increased amount of carbon dioxide. So the factors that affect your pulmonary ventilation, there's some intrinsic factors such as infections, allergic reactions, or unresponsiveness. The unresponsiveness may be caused by a tongue obstructing the airway. Extrinsic factors that can cause the airway obstruction would be something like a trauma. factors that affect your respiration. External factors, atmospheric pressure and the partial pressure of oxygen in the ambient atmosphere. So if there's a lack of oxygen. Internal factors, such as conditions that reduce the surface area for gas exchange and consequently decrease the body's oxygen supply, leading to inadequate tissue perfusion. Things like pneumonia, pulmonary edema, and COPD or emphysema. Circulatory compromise. So this is obstruction of the blood flow to individual cells and tissues, which can be related to a trauma emergency. You could be related to a simple or a tension pneumothorax, an open pneumothorax, a hemothorax, or a hemopneumothorax. Can anybody tell me what a pneumothorax is?
It's air trapped outside the lung in the chest cavity.
That's right. So pneumothorax, sometimes it's referred to as a collapsed lung. It's a condition where air is leaking into the space between the lungs and the chest wall. Could be caused by blunt or penetrating chest trauma, medical procedure, or even lung diseases. Now, on the other hand, what's a hemothorax?
It's blood that does the same thing.
That's right. It's very, very similar, but instead of air, it's blood. You've got blood outside of the lungs. And hemopneumothorax is one big long word. You've now got blood and air outside of the lungs. Some of the other different causes of circulatory compromise could be blood loss, could be anemia, hypovolemic shock, or vasodilatory shock. What is anemia? Somebody other than Rich, what is anemia? Cyrus says low blood count. Yeah, so anemia is when your body doesn't have enough healthy red blood cells. Hypovolemic shock. Somebody define that for me? Anybody?
When there's
All right, Alex says low plasma. So yeah, hypovolemic shock, it's essentially low blood volume. How about vasodilatory shock?
It's when your blood vessels dilate and the volume or the pressure is reduced.
Very good. So this became very big lately with the introduction of COVID and some of the other different respiratory illnesses that have been going around. You know, we're all still wearing masks. We're all still wearing protective eyewear. Anytime you're doing an aerosol generating procedure, even outside of COVID protocols, you really should be wearing your mask and your protective eyewear to protect yourself. Some of these aerosol generating procedures are CPR, NEP treatments, endotracheal intubation, or CPAP. Basically, the science behind this is as you're pushing air into somebody, stuff's going to come back out. You don't want that stuff getting into your own airway or your own face or your own eyes, anything of that sort. Protect yourself. Recognizing adequate breathing. So 12 to 20 breaths per minute in an adult is considered adequate breathing. You're looking for a regular pattern of inhalation and exhalation. You're listening for bilateral, clear, and equal lung sounds. You're looking for regular, equal chest rise and fall. And you're looking for an adequate tidal volume or depth of breathing. On the other hand, abnormal breathing, less than 12 breaths per minute, or more than 20 breaths per minute. An irregular rhythm, diminished, absent, or noisy breath sounds. A reduced flow of expired air at the nose and mouth. So you're not feeling the air come out of the nose and mouth as they're trying to breathe. Unequal or inadequate chest expansion. Increased effort of breathing. Shallow depth. Skin that is pale, cyanotic, cool, or moist. Skin that pulls in around the ribs or above the clavicles during inspiration. A patient may appear to still be breathing after the heart has stopped. We call these agonal gasps. This is that noisy, dying breath sound that you hear as a patient is coming to the end of life. Cheyne-Stokes respirations are seen in patients with stroke or head injury. So with the Cheyne-Stokes breathing, you see irregular respirations followed by a period of apnea, or apnea meaning the absence of a breath. Ataxic respirations have an irregular or unidentifiable pattern and may follow a serious head injury. Patients experiencing metabolic or toxic disorder may display other abnormal respiratory patterns, such as Kussmaul respirations. Kussmaul respirations are deep, rapid respirations commonly seen in patients with metabolic acidosis. Patients with inadequate breathing need to be treated immediately. So, emergency medical care for breathing difficulty, airway management, supplemental oxygen, ventilatory support, a solid assessment of the respiration. Even though the patient might be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may be compromised by a whole bunch of different factors. High altitude poisonous gases like carbon monoxide or enclosed spaces. A patient's level of consciousness and skin color are excellent indicators of respiration. A patient who presents with an altered level of consciousness or skin color that's pale, that can tell you that they're not perfusing correctly. When you're assessing the patients, you have to consider proper oxygenation, which can be assessed with pulse oximetry devices. The oxygen saturation, or the SpO2, is a measure of the percentage of hemoglobin molecules that are bound in arterial blood. A pulse oximeter measures the percentage of hemoglobin saturation, and 94% while breathing room air is our goal number. Sometimes in conditions like a stroke or a heart attack, we may still give oxygen if the SpO2 is at or above 94%. Pulse oximeters can take as long as 60 seconds to reflect changes in a patient's oxygenation status. The patient can develop respiratory insufficiency well before the pulse oximetry values begin to decline. Pulse oximetry is a routine vital sign, and you can use it as part of any of your patient assessments. However, the important part here, as they said, it can take as long as 60 seconds to reflect a change. Treat your patient, not the machine. Just because you see a number, you also have to look at your patient, and there's other factors there. You're looking for those things like, are they truly having difficulty breathing? Do you see the accessory muscle use? What is the rate and the depth of their breathing? What does their skin look like? What is their mental status like? All of those things should be signs of whether or not they're perfusing correctly. Don't just rely on the SpO2 number. One of the biggest things that can affect that SpO2 number is the patient being cold. If their fingers are cold and you put that probe on them, that number may not be accurate. Treat your patient, not your machine. Make sure you're assessing them appropriately and looking for the different signs and symptoms of adequate or inadequate ventilation. End-tidal CO2 is the measurement of the maximal concentration of CO2 at the end of an exhaled breath. A low CO2 level could indicate hyperventilation or decreased CO2 return to the lungs. It can also reduce CO2 production at the cellular level. A high CO2 level may indicate the patient retaining CO2 secondary to ventilation inadequacy, such as apnea or the absence of breathing. End-tidal CO2 is measured using capnometry and capnography devices. Capnometry refers to the use of a device that provides a digital numeric reading of the end-tidal CO2 level. Capnography provides both the numeric reading and a graph from breath to breath. The normal range is 35 to 45 millimeters of mercury. And this can be used in spontaneously breathing patients with an adequate airway using a special nasal cannula. So most every cardiac monitor out there these days has the ability to do this. And typically you would either be putting this measurement device on a bag valve mask or in a nasal cannula form. Sunday during your practical session, Kevin's going to go in depth with end-tidal CO2, show you how it works, show you what we're talking about with the waveform and the number. Important takeaway though, 35 to 45 is your normal range. So the first step in managing an airway is making sure that you open the airway. Rapidly assess whether an unconscious patient has a patent airway and pulse and is breathing adequately. Position them supine. What does supine mean? We've covered that one in one of our chapters so far. What is supine?
On their back.
On the back, that's right. Unconscious patients should be moved as a unit because of the potential for a spinal injury. So you've got to think about a spinal injury when you're moving a patient. Most common airway obstruction is the tongue. So you can see in your little diagram here, the tongue can flop back and it can block your air passage. Head tilt, chin lift. I alluded to this in some of the other presentations we've done before, and this is something we'll practice in person on Sunday. This will open the airway in most of your patients, and this is for patients who have not sustained or suspected of having sustained spinal trauma. Sometimes this is all you need for a patient to start breathing, is just to get that airway back opened. So with the patient supine, you're going to position yourself behind the patient's head. You're going to place the heel of one hand on the patient's forehead and apply firm backward pressure with the palm. You're going to place the fingertips of the other hand under the patient's lower jaw, and you're going to lift the chin upward with the entire lower jaw helping to tilt the head back. Again, we'll go over this in person. We'll demonstrate it. It'll make more sense when you can see it. The jaw thrust maneuver. So this is for the patients that you suspect may have a spinal injury. You're going to kneel above the patient's head. You're going to place your fingers behind the angles of the lower jaw. Move the jaw upward and use your thumbs to help position the lower jaw. Again, we'll demonstrate that on Sunday. Even if you've opened the airway, you may still need to open the mouth. To open the mouth, you're going to place the tips of your index finger and thumb on the patient's teeth. Open the mouth by pushing your thumb on the lower teeth and your index finger on the upper teeth. The pushing motion will cause the index finger and the thumb to cross over each other, which is why it's called the cross finger technique. So you've got a little demonstration of the jaw thrust maneuver here. Again, when we can actually demonstrate it in person, it's going to make a lot more sense to you. Suctioning. So the airway has to be clear to ventilate properly. You have different options out there for suction. There are hand-operated devices like you see on the left. There's fixed equipment like you'd see in an ambulance in the middle there. And then there's portable units like you see on the right. A portable or fixed unit should have a wide-bore, thick-walled, non-kinking tube, a plastic rigid pharyngeal suction tip, commonly called a Yankower. It's the best for infants and children. We also have non-rigid plastic catheters called a French catheter. Those can be used to suction the nose and liquid secretions in the back of the mouth in situations when you can't use that rigid catheter. They should have a non-breakable disposable collection bottle. They may have a water supply for rinsing the tip of the suction catheter. Before you insert a catheter, you need to measure to make sure you have the right size. You'd use the same technique as when you measure for an oropharyngeal airway or an OPA. We'll demonstrate that again on Sunday. So you need to inspect your suction equipment regularly. So that should be something that you're checking at the beginning of your shift during your truck check. Make sure you unplug the portable suction unit. Make sure the battery is actually charged and going to last. You're going to want to check and make sure that it's properly assembled and ready to go. Turn it on and test it to make sure that you can get a vacuum pressure of more than 300 millimeters of mercury. And when you're going to use it, you're going to want to make sure you select and attach the appropriate suction catheter to the tubing. Never suction the mouth or nose for more than 15 seconds at a time for adult patients, 10 seconds for children, 5 seconds for infants. Suction can result in hypoxia. You never want to touch the back of a patient's airway with the suction catheter. This can activate their gag reflex. That's why we're measuring. We don't want to be jamming that suction catheter way down their throat, activating their gag reflex, and causing them to vomit, filling their airway with vomit. It's defeating the whole purpose at that point. Sometimes a patient might have secretions or vomit that can't be suctioned quick and easy. Some units wouldn't be able to remove an object like a tooth, a foreign body, or food. In those cases, remove the catheter from the patient's mouth, log roll the patient on their side, and clear their mouth with a gloved finger. If a patient requiring assisted ventilations produces frothy secretions, as quickly as you can, you need to suction them. Suction them for 15 seconds, unless if it's an infant or a child. Ventilate them for 2 minutes, and continue that alternating pattern of suctioning and then ventilating until you've got all of those secretions out of the airway. Basic airway adjuncts. An airway adjunct prevents the obstruction of the upper airway by the tongue and allows for passage of air and oxygen to the lungs. The most commonly used is an oropharyngeal airway. It's a plastic device that goes in the mouth and keeps the tongue from blocking the upper airway, and it makes it easier to suction the oropharynx. The indications for use would be an unresponsive patient without a gag reflex. Apneic patients that are being ventilated with a bag mask device. Contraindications. A contraindication being a time where you would not use this is a patient that's conscious or a patient who has an intact gag reflex. If you go to put this device in the patient's mouth and they start to gag, pull it back out. Again, we don't want them vomiting and further risking their airway. An oral airway that's too large could push the tongue back into the pharynx, which blocks the airway. An oral airway that's too small could block the airway directly, like a foreign body obstruction. Nasopharyngeal airways. So this is used in a patient who has an intact gag reflex, but still can't manage their own airway. Indications: a semi-conscious or unconscious patient with an intact gag reflex, and a patient who otherwise will not tolerate an oropharyngeal airway. Contraindications would be a severe head injury with blood draining from the nose, history of a fractured nasal bone. Some different ways to maintain the airway. You can use the recovery position. This is just used to help maintain a clear airway in an unconscious patient who's not injured and is breathing on their own. You see with the position this person's laying in, they're on their side, they've got their knee in front of them to support them, they've got their arms in front of their face, kind of holding their head up. If the patient were to vomit, for example, it's not going to pool in their mouth, it's going to leak out of their mouth onto the floor in front of them. It's going to prevent that airway from becoming blocked. Always give supplemental oxygen to patients who are hypoxic because not enough oxygen is being supplied to the tissues and the cells of the body. Some of the tissues and organs, such as the heart, central nervous system, lungs, kidneys, and liver, need a constant supply of oxygen to function normally. Never withhold oxygen from any patient who might benefit from it, especially if you need to assist their ventilations. Supplemental oxygen equipment, oxygen cylinders. The oxygen that you're going to give to the patients is typically supplied as a compressed gas in a green steel or aluminum cylinder. Check that the cylinder is labeled for medical oxygen. Look for letters and numbers stamped into the metal on the collar of the cylinder. Check the month and year stamps indicating when the cylinder was last tested. Aluminum cylinders are tested every 5 years. Composite cylinders are tested every 3 years. The length of time that you're going to be able to use that oxygen cylinder will depend on the pressure that's in the cylinder and the flow rate. And liquid oxygen is becoming a more commonly used alternative to the compressed gas. Safety considerations: handle your gas cylinders carefully. They're under pressure. Make sure that the correct pressure regulator is firmly attached before you transport it. A puncture or a hole in one of these oxygen tanks can turn it into a deadly missile. Secure the cylinders with mounting brackets when they're stored on the ambulance. And oxygen cylinders that are in use during transport should be positioned correctly and secured. Each portable cylinder of a specific gas type has a given pattern and a given number of pins following an accepted national standard. The pin indexing system prevents an oxygen regulator being accidentally connected to an incorrect gas cylinder. When you're preparing to administer oxygen, check that the pinholes on the cylinder exactly match the corresponding pins on the regulator. For large cylinders, the safety system is the American safety system. Oxygen cylinders are equipped with a threaded gas outlet valve. Inside and outside, the thread sizes vary depending on the gas that's in the cylinder, which again prevents the accidental attachment of a regulator to the wrong cylinder. Pressure regulators reduce the cylinder's pressure to a useful therapeutic range for the patient, which is usually 40 to 70 psi. After the pressure is reduced to the workable level, the final attachment for delivering the gas is one of the following: a quick connect female fitting that will accept a quick connect male plug from a pressure hose or a ventilator or resuscitator, or a flow meter that will permit the regulated release of gas measured in liters per minute. The flow meters are usually permanently attached to a pressure regulator on emergency medical equipment. A pressure compensated flow meter incorporates a float ball within a tapered calibrated tube, and it's affected by gravity, and it must always be upright. The burden gauge flow meter is a gauge calibrated to record the flow rate, and it can be used in any position. So some of the hazards, combustion, oxygen flammable, and oxygen toxicity. Oxygen doesn't burn or explode, but it does speed up the combustion process. Keep any sources of fire away. Make sure the area you're using the oxygen is adequately ventilated, and never leave an oxygen cylinder standing unattended. Not all patients need a high concentration of oxygen. Excessive supplemental oxygen can have a detrimental effect on patients with things like COPD. Oxygen toxicity refers to damage to the cellular tissues due to excessive oxygen levels in the blood. Increased cellular oxygen levels contribute to the production of oxygen-free radicals, which can lead to tissue damage and cellular death in some patients. And again, when you have pulse oximetry available, we're looking to maintain at or above 94% for most patients. Our oxygen delivery equipment. We have non-rebreathing masks, we have bag mask devices, and we have nasal cannulas. The non-rebreathing mask, it has a mask and a reservoir bag. Oxygen will fill the reservoir bag attached to the mask by a one-way valve. Exhaled gas will escape through the flapper valve ports at the check areas of the mask, and it prevents the patient from rebreathing their exhaled gases. It's very important to make sure that you fill the reservoir bag before you place it on the patient. You've got to adjust the flow rate so the bag doesn't collapse when the patient inhales. Typically 10 to 15 liters per minute for these. If the bag's collapsing, increase the flow rate. When the oxygen therapy is discontinued, remove the mask from the patient's face. And these bags come in adult, pediatric, and infant sizes. A nasal cannula. It delivers oxygen through two small tube-like prongs that fit in the nostrils. It can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. Typically, we wouldn't go over 6 liters per minute with these. It's uncomfortable for the patient to have that much oxygen or that much pressure going into their nose. The nasal cannulas are used for patients with mild hypoxemia. A patient who breathes through the mouth or has a nasal obstruction will get little to no benefit from these. Some EMS systems have humidified oxygen if you're doing extended transports. Basically, when these are in a patient's nose for a long amount of time, it dries the nose out. So attaching some form of a humidifier to it will help kind of keep that area from drying out and becoming painful. Partial rebreathing masks, they're similar to a non-rebreathing mask, except they don't have the one-way valve between the mask and the reservoir. And the patients will rebreathe a small amount of their exhaled air. Venturi masks. They have a number of attachments, and they can vary the percentage of oxygen while a constant flow is maintained from the regulator. It's a medium flow device that delivers 24 to 40% of oxygen depending on the manufacturer. Tracheostomy masks. Patients that have a trach don't breathe through their mouth and nose. They have a port on their throat. These masks go over that port to help give them the oxygen. You can use a face mask if you don't have the specialized mask. A lot of times these patients are going to have their own, but if for some reason they don't, you can just use a normal face mask for this. A tracheostomy mask must cover the tracheostomy hole and have a strap that goes around the neck. Again, they may not always be available in an emergency setting. You can improvise by placing a face mask over the stoma. Basic airway and ventilation techniques are extremely effective when they're administered properly. Like we talked about earlier, the signs and symptoms of inadequate ventilation, altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. So if you're going to assist a patient's ventilation with a bag mask device, if the patient is conscious, explain what you're doing to the patient. You've got to tell them, I'm going to put a mask over your face and help you breathe. You've got to keep them calm. Just coming up and slapping a mask on someone's face can be pretty stressful for them. You don't want to just go up and do that. You want to give them a heads up, what's going on, and talk them through the process. After you've got them kind of comfortable with what's about to happen, you put the mask over their nose and mouth. And each time the patient breathes on their own, you want to squeeze the bag. So you're kind of maintaining the same rate as the patient. After the initial 5 to 10 breaths, slowly adjust your rate and deliver an appropriate tidal volume. Adjust the rate and tidal volume to maintain an adequate minute volume. So if these patients are breathing on their own, you're trying to match exactly what they're doing. You don't want to breathe faster than them. You don't want to breathe slower than them. You've got to kind of match their inspiration and exhalation. Once a patient is not breathing, begin your artificial ventilation immediately. And you can use a mouth-to-mask technique, or you can use a 1 or 2 person bag mask device. Normal ventilation versus positive pressure ventilation. Artificial ventilations are necessary to sustain life, but they're not the same as normal breathing. In normal breathing, the diaphragm contracts and the negative pressure is generated in the chest cavity, which sucks the air into the chest. Positive pressure ventilation generated by a device just forces air into the chest cavity. It doesn't actually have the movement of the diaphragm. With positive pressure ventilation, increased interthoracic pressure causes compression of the vena cava and reduces blood return to the heart, which reduces the amount of blood pumped by the heart. More volume is required to have the same effect as normal breathing, which pushes the airway walls out of their normal anatomic shape. Air is forced into the stomach, causing gastric distension that could result in vomiting and aspiration. The EMT must regulate the rate and volume of artificial ventilations to help prevent the drop in cardiac output. Ventilation rates for apneic patients with a pulse. In an adult, you're looking 1 breath every 6 seconds. For a child, you're looking for 1 breath every 2 to 3 seconds. And for an infant, you're looking for 1 breath every 2 to 3 seconds. Mouth-to-mouth and mouth-to-mask ventilation. Typically, you're going to use a barrier device when you're doing this. A mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation. Typically, these are not things that we're doing in the field. This would be more of like you're out shopping and you witness somebody go down and you don't have all your tools. It's very rare that in the field you would do mouth-to-mouth on a patient that you don't know. Bag mask device. It provides less tidal volume than mouth-to-mask ventilation, but delivers a much higher concentration of oxygen with a flow rate of 15 liters per minute and an adequate mask-to-face seal. Some of the components, it has a disposable self-inflating mask, no pop-off valve, or if one is present, the capability of disabling the pop-off valve. It has an inline viral filter, an outlet valve that is a true value for non-rebreathing, an oxygen reservoir that allows for delivery of a high concentration of oxygen, a one-way no-jam inlet valve stem that provides an oxygen flow rate at a maximum of 15 liters per minute with a standard 22 millimeter fitting for your face mask or an endotracheal tube. It has a transparent face mask. It has the ability to perform under extreme environmental conditions. The volume of air delivered is based on observing chest rise and fall. And again, this is something that we're going to practice with. once we do our in-person sessions. Gastric distension. So this occurs when artificial ventilation fills the stomach with air. It's most likely to occur when you ventilate the patient too forcefully or too rapidly with a bag mask device or a pocket mask. The airway is obstructed as a result of a foreign body or improper head position. And you should give slow, gentle breaths during artificial ventilation over 1 second. Preventing or alleviating the distension. Ensure the patient's airway is appropriately positioned. Ventilate them at the appropriate rate, and ventilate them with the appropriate volume. If gastric distension makes it impossible to ventilate the patient and an ALS provider is not available to do a decompression, you can consider applying pressure over the upper abdomen as a last resort. If vomiting occurs as a result, turn the patient on their side and suction or wipe out the mouth with your gloved hand, and then return the patient to a supine position and continue your rescue breathing. Passive ventilation, also called passive oxygenation or apneic oxygenation. Air movement in and out of the chest cavity occurs passively as a result of compressing on the chest. When the chest is compressed, air is forced out of the thorax, and as the chest recoils following a compression, a negative pressure is created within the chest, which results in a vacuum, sucking the air into the chest cavity, similar to what occurs during active inhalation. Passive ventilation can be enhanced by inserting an OPA. Try that again. Passive ventilation can be enhanced by inserting an OPA and providing supplemental oxygen. Automatic transport ventilators or resuscitators. It's a ventilation device attached to a control box that allows the variables of ventilation to be set. And this would free the provider to perform tasks such as maintaining the mask and CO or ensuring continued airway patency. Constant reassessment of the patient is necessary with these. This is not something that many services around this area carry. All right, before we move into CPAP, let's take a quick 5-minute break.
This conference will now be recorded.
All right, let's talk CPAP. So CPAP is non-invasive ventilatory support for respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night to maintain their airways while they sleep. CPAP in the pre-hospital environment has proven to be an excellent adjunct in the treatment of respiratory distress associated with COPD, acute pulmonary, and acute bronchospasm. CPAP is becoming widely used at the EMT level. As EMTs in both Maine and New Hampshire, you are able to use CPAP. So CPAP works by increasing the pressure in the lungs, which will open the collapsed alveoli and push more oxygen across the alveolar membranes, forcing interstitial fluid back into the pulmonary circulation. So effectively, CPAP is just increasing the pressure. The therapy is typically delivered through a face mask, which is held to the head with a strapping system. It has a really good seal with minimal leakage between the face and the mask. Many CPAP systems will use oxygen as the driving force to deliver the pressure to the patient. Patients benefit the most from CPAP during their exhalation. Use caution with patients with potentially low blood pressure because CPAP will cause a drop in cardiac output. Indications for CPAP. The patient is alert and able to follow commands. The patient displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or obstructive pulmonary disease such as COPD. The respiratory distress occurs after a submersion incident, so after they've been submerged in water. The patient is breathing rapidly, and so much so that it's affecting their minute volume. or the pulse oximetry reading is less than 90%. Contraindications, times we're not going to use CPAP. Patients that are in respiratory arrest or has agonal respirations, a patient who is hypoventilating, hypo meaning not enough, a patient that can't speak, a patient that's unresponsive or otherwise unable to follow verbal commands, a patient that cannot protect his or her own airway, or a patient with hypotension or low blood pressure. Patients that have signs and symptoms of a pneumothorax or chest trauma. Patients that have chest trauma like this, we don't want to be increasing the pressure in their chest. It's going to cause more damage. A patient who has a tracheostomy, or the hole in their throat that they're breathing through, putting a mask on their face is just going to blow air out that hole. It's not going to do much good for them. Active gastrointestinal bleeding or vomiting. A patient that's experienced facial trauma. A patient that's in cardiogenic shock. A patient that cannot sit upright. A patient where the CPAP system mask and strap can't fit them properly. Or a patient that cannot tolerate the mask. So when they say they can't tolerate the mask, something we can do in class, we'll have a CPAP mask we can play with, and if you'd like to put it on and try it, you can do that. The best description I've heard is it's similar to putting your head out the car window while you're driving down the road, and you get that rush of wind in your face. It's very similar to that feeling. So a patient that is claustrophobic or doesn't do well with things right in their face, they have a really hard time with CPAP. And just CPAP alone, even when it's working and even when it's helping them breathe, it creates a lot of anxiety with these patients. Again, just like we were talking about when you're using a bag valve mask on a patient that's conscious, you're going to want to talk to them. You're going to want to tell them, hey, I'm going to put this mask on your face. I'm going to strap it to your head. It's going to feel claustrophobic. There's going to be pressure, but it's going to help you breathe. It's going to make you feel better. Talk to them throughout the whole process. Keep talking to them and try to keep them as calm as you can. There are some patients that just can't tolerate it, and it's just not going to work. And unfortunately, at that point, you got to look for other options to try and keep them breathing adequately. But the best thing you can do is talk them through it and try to keep them calm. So some of the components of the CPAP unit, they have some form of a generator. Most of the ones you'll see on the ambulances, they just plug into the oxygen port on the truck, and the amount of oxygen you put through them will create the PEEP. PEEP is the positive end expiratory pressure, and that's how we measure the level of CPAP. Some of them, they do have machines out there that have an actual box that creates the pressure. You plug the box into the wall of the ambulance and it creates pressure on its own. That one would look more like what you'd use at home at night if you have a nighttime CPAP. So they have some form of a generating device, whether it be just plugging into the oxygen or having the actual box. They have a mask. They have a circuit, which contains corrugated tubing. So that's actually what connects up to the patient's face. They have a bacteria filter, and they have a one-way valve. The CPAP generator is going to create resistance throughout the respiratory cycle. The resistance creates back pressure in the airway that pushes open the smaller airway structures, such as the bronchioles and the alveoli, as the patient's exhaling. The amount of pressure can be determined by adjusting a valve within the CPAP system, or sometimes they have a separate valve that you can attach to them. A pressure of 7.0 to 10.0 centimeters of water is generally an acceptable therapeutic range. And again, most CPAP units are going to be powered by oxygen, so it's important to have a full cylinder of oxygen when you're using CPAP. CPAP uses a ton of oxygen, so you got to make sure you have a full tank. Like we talked about, some patients are going to find CPAP claustrophobic, and they're going to resist application of the mask. Best thing you can do is to coach them through. Don't force it. Due to the high volume of pressure that's generated by the CPAP, pneumothorax is a risk. High pressure in the chest can lower the patient's blood pressure. If the patient's showing signs of deterioration, remove the CPAP and use a BVM instead. If their blood pressure is dropping too drastically, if they're resisting it, whatever the case, if it's not working, if it's not creating a positive outcome, take it off and go with a BVM. Special considerations, stomas and trach tubes. Patients who have had a laryngectomy have a permanent tracheal stoma, which is the opening in the neck that connects the trachea directly to the skin. It's known as a tracheostomy. You've got a good picture of one there. Sometimes they look just like you see right here. Sometimes they have a port of sorts put there. Sometimes that port has a cap on it. And one of the things that you'll experience at some point is you'll have a patient who's generating too much phlegm and their tracheostomy gets plugged. And that's where these stomas need to be suctioned. In a lot of places, that is not a skill that you can do as an EMT. That's something that you need an ALS provider to do. But that is one of the considerations for somebody that has a stoma or a tracheostomy tube. Sometimes that hole, especially if it's got a cap on it, gets plugged up with phlegm. If the patient has a trach tube, you need to ventilate through that tube with a BVM. If they have the actual stoma, if they have the actual port on there, your bag valve mask is actually going to fit right onto that stoma. And you can just use your bag valve mask to ventilate them. Like we talked about earlier, if they don't have their own oxygen mask, you can use just a regular oxygen mask off of your truck. And you should always use 100% oxygen attached directly to the bag valve mask device if that's the route you're going. If the patient has a stoma but no tube is in place, use an infant or a child mask with your bag mask device to make the seal over the stoma. So an adult mask is pretty good in size. You've only got a small hole you need to cover. The smaller the mask, the better. When you're ventilating them through their stoma opening, you're going to want to cover their mouth and nose with a hand. Otherwise, the air is going to move upwards. You obviously don't want the air that you're ventilating into the patient to leak out of their nose and mouth. When it's time to exhale, you got to release that seal to let the air come out of their nose and mouth. Like we talked about before, if you can't ventilate them with the stoma, you can try suctioning using a French tip catheter. If you're going to give mouth to mouth to a patient with a stoma for some reason, you'd want to cover the stoma hole. So if you're ventilating through the stoma, cover the mouth and nose. If you're ventilating through the mouth and nose, cover the stoma. One or the other has to be covered up. If an obstruction completely blocks the airway, it is a true emergency, which is going to result in death if it's not treated immediately. In an adult, a sudden foreign body airway obstruction usually occurs during a meal. In a child, it could be while eating, it could be playing with small toys, could be crawling around the house. The tongue is the most common airway obstruction in the unconscious patient. Some causes that don't involve foreign bodies could be swelling from an infection or an allergic reaction. Could be trauma. With a mild airway obstruction, patients are still exchanging air, but they're having varying degrees of respiratory distress. And you need to take great care to prevent the mild obstruction from becoming severe. The patient might have noisy breathing, they might be coughing, they might be wheezing. With good air exchange, the patient can cough forcefully, although you might hear wheezing between the coughs. If they can cough forcefully, you know they're getting good air exchange. As long as the patient can breathe, cough forcefully, or talk, don't interfere with their efforts to expel the object on their own. Continually reassess their condition. On the other hand, with poor air exchange, the patient's going to have a weak, ineffective cough and may have increased difficulty breathing, stridor, and cyanosis. Stridor is a sound that indicates a mild upper airway obstruction. This is something we need to treat immediately because it's a severe airway obstruction. Severe airway obstruction. Patients cannot breathe, they cannot talk, and they cannot cough. The patient may clutch or grasp the throat, which is the universal distress signal. They may begin to turn cyanotic, and they're going to have extreme difficulty breathing. So you see a patient doing that with their hands, that is the universal sign that they are choking. If they're conscious, you need to provide immediate treatment. If they're not treated, they're going to become unconscious. If the patient is unresponsive, not breathing, and has no pulse, we do CPR with chest compressions. Excuse me. Emergency care for foreign body airway obstructions. Head tilt chin lift to clear the tongue. If you've got spinal trauma, use the jaw thrust. Large pieces of vomited food, mucus, loose dentures, blood clots in the mouth, sweep them out with your gloved hand. If you have a suction available, use the suction to maintain the clear airway. Abdominal thrusts, or the Heimlich maneuver, are the most effective way of dislodging and forcing an object out of the airway for a conscious patient. When you're doing these abdominal thrusts, you're using the residual air that's always present in your lungs, and you're compressing it upwards, trying to expel the object. You're going to use those abdominal thrusts until either the object comes out or the patient goes unresponsive. For an unresponsive patient with a severe foreign body airway obstruction, reassess them to confirm that they're apneic, not breathing, and unable to ventilate. If they're unresponsive, begin chest compressions just like you would for CPR, following the 30 compressions to 2 breaths ratio. At the completion of your 30 compressions, you're going to open the mouth and you're going to look in the back of the oropharynx for any foreign objects. If you can see it, pull it out. We do not do blind sweeps. Sorry about that. We do not do blind sweeps anymore. They used to teach that you do blind sweeps and you blindly put your fingers in people's mouths. That is a great way to get your finger bitten off. We don't do blind sweeps. We only go in for it if we can see it. The other problem with blind sweeping is you might push it further down in the airway, making their obstruction worse. Dental appliances like dentures, crowns, bridges, braces. If you can pull it out, do it. Manually remove it before you provide ventilations. If the dentures fit well and they're not moving and they don't easily come out, leave them alone. They do provide structure to the face, and they're going to help you provide the face to mask seal. If they're in there tight and they're not moving around, keep them there. They're actually going to help you. If they're loose, if they're moving around, pull them out. If you do pull their dentures out, put them in a container of some sort. Make sure they stay with the patient. They're very expensive. Try not to lose them on the patient. Facial bleeding. Airway problems can be challenging in patients with serious facial injuries. The blood supply to the face is very rich, so injuries can result in severe tissue swelling and bleeding into the airway. Control the bleeding with direct pressure and suction as necessary. Assisting with ALS airway procedures. So when a critical patient needs an advanced airway intervention, a paramedic, or in some states even an advanced EMT, will perform the skill. But as an EMT, you're going to need to help. You're going to need to perform BLS airway and ventilation maneuvers, as well as help monitoring the patient. When we're talking about endotracheal intubation, which is something a paramedic is going to do, you're going to need to pre-oxygenate the patient, which is going to include using the bag mask and either an oral or a nasal airway with a proper seal to pre-oxygenate the patient, make sure they've gotten all their oxygen. You might maintain a high-flow nasal cannula on the patient for the pre-oxygenation, and you might leave that in place while they're intubating. Some different equipment set up, personal protective equipment like face masks and eye shields. If you don't already have them on, you're going to want them. Suction units, you're going to want to prepare a suction unit if the paramedic's intubating. They're going to use something called a laryngoscope handle and blade. That's the big piece of metal that they actually go in at an angle with. Something called McGill forceps, which would be used to remove an object from the airway. That's something a paramedic can use to actually pull something that's deep in the airway. The actual endotracheal tube is the tube that they're going to insert. Something called a stylet or a tube introducer or a bougie. That's a rigid piece of metal that they're going to use to help get the tube where it needs to be. Lubricant is used. 10 ml syringes are used. Confirmation devices. We were talking about end-tidal CO2. That is one of the confirmation devices. So once they have the tube in place, we can pop the little connector on the end of it, attach it to the cardiac monitor, and use that to determine their end-tidal CO2. That can confirm that the tube is in the right spot. There's a couple different methods of determining a tube is in the right spot. You can see mist inside the tube as the patient is respirating. You can see chest rise when you put the bag mask on it and you ventilate them. You'll actually see their chest move. And then you can listen to their lung sounds. Something important when they're intubating is listening to the sounds of the stomach to make sure you don't hear air going into the stomach to prevent that gastric distension that we talked about earlier. They're going to use a commercial securing device. So that's a device that wraps around the patient's head and neck, and it actually clamps down on the tube to hold it in place so it doesn't get ripped out. And there's other alternate airway devices that they might use, such as a supraglottic airway. EMTs in New Hampshire can actually use supraglottic airways. So this is something that we're going to cover. These are things like King tubes, LMAs. In Maine, as far as I know, you still cannot use these at the EMT level. Another item is a cricothyrotomy kit. That's something a paramedic is going to use as an absolute last case scenario. They can actually cut a hole in the patient's throat to help them breathe. All right, so we've got this mnemonic here, Be Magic. Pre-oxygenation is the first step. Evaluating for airway difficulties. Manipulate the patient into the right position. Attempt the first pass intubation. There we go, my words. Supraglottic airway if they can't intubate. And then confirming the successful intubation. If it's not successful, you've got to correct it. So effectively, the paramedic's going to attempt to intubate with their tube. If their tube doesn't work, they're going to go with the supraglottic. If you're in New Hampshire, that might be something you're helping them with. We're going to go through all these different tools, and we're going to go through these different processes in person in the classes. We'll be hands-on with this. It's a lot easier to learn these kinds of things hands-on rather than reading it off a slide. So we've reached our review. We'll do it as we always do with the chat box. So breathing is controlled by an area in what? Excellent, B. The pons and the medulla are the respiratory centers in the brainstem that control your breathing. The EMT should assess the patient's tidal volume by doing what? Perfect. A. Looking for chest rise. Remember, the tidal volume is the volume of the air that's going in and out of the lungs in a single breath. So chest rise is going to be what tells you how much is coming in and out of the lungs. In an otherwise healthy individual, the primary stimulus to breathe is what? Good. C. Under the control of the brainstem, rising levels of carbon dioxide in the arterial blood normally stimulate the breathing in an otherwise healthy patient. So remember, your body is not trying to increase the oxygen level, it's trying to get rid of the carbon dioxide. Signs of adequate breathing in the adult include all of the following except for what? Good. Shallow chest rise is not a good thing. That's the reduced tidal volume we just talked about. During insertion of an oropharyngeal airway into an unconscious patient, she begins to vomit. What is the first thing you should do? So this is one of those questions that's going to be a lot like your national registry exam at the end of the class. You're given multiple answers that are correct, and you have to choose the one that's the most correct. As a general rule, when it looks like there's more than one answer, if you err on the side of ABCs, airway, breathing, circulation, you'll probably be correct. You're all right. Ultimately, yes, removing the airway right away is important, but prior to that, put the patient on her side. Reason for that is you're trying to clear that airway before they aspirate that vomit or breathe that vomit into their lungs. So the correct answer is A. Because they began to vomit, you want to move them on the side and then remove the airway. That's going to allow the vomit to drain from their mouth and prevent them from breathing it in. In which of the following patients would a nasopharyngeal airway be contraindicated? All right, good. Remember, so contraindicated are the times we're not going to do something or use something. And for nasal airways, we're not going to use them on a patient that has a head or face injury. So the answer is C, the patient that fell 20 feet and landed on his or her head. You're delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he begins to complain of a burning sensation in his nose. What should you do? Very good. C. So this is the, like we were talking about, the oxygen humidifiers. The dry oxygen through the nasal cannula, it really dries out your nose. It causes that burning sensation. Unfortunately, most of our ambulances don't actually carry humidified oxygen. That's more of something you'd see in like a nursing home or even in the hospital setting. But if you have it, it's great for this purpose. A patient is found unconscious after falling from a third-floor window. His respirations are slow and irregular. You should do what? All right, this is another one of those lovely questions where you get multiple answers that could be correct. So there's a couple of key points here that you want to pull out of this question. The patient is unconscious. They fell from a third-story window, so they have trauma. Respirations are slow and irregular. So because the patient is unconscious and their respirations are not adequate, we're going to go right to assisting their breathing with a bag mask device. The answer is D. So non-rebreathing mask, if the patient was conscious, you may go more towards the non-rebreathing mask. Where the patient is unconscious, you're going to want to assist their respirations right off the bat with the bag valve mask. When ventilating an apneic adult with a bag mask device, you should squeeze the bag until when? Very good, D. Looking for chest rise. You and your partner are ventilating an apneic patient when you notice that his stomach is becoming distended. What should you do? Very good, B. So when you start to see that gastric distension, the first step is to try opening their airway and making sure that that air has a way to dispel. All right, so that finishes our slideshow for tonight. Let's take a 5-minute break, and I want to come back and listen to some lung sounds, and then we'll go from there. So let's take 5.
This conference will now be recorded.
All right, so we're gonna play some different lung sounds here, and we'll talk about some of the different causes of these lung sounds. Fair warning, check your volume. I have no idea how loud these are gonna be on your side. So I'm gonna play the first one, which is just normal lung sound. So this is what you expect to hear in most patients. All right, were you able to hear that okay? All right, I see some thumbs up. Perfect. All right, so next we're going to listen to RALs, or fine crackles. Apparently an ad.
At Custom Ink, we can help you create custom products with a meaningful...
So some of the different reasons you might hear RALs or crackles: pneumonia, congestive heart failure or CHF, bronchitis as well. Listen to some wheezing. So here in the video, you see they say, think of it like whistling through a narrow tube. So these are your asthma patients, your COPD patients. These are your patients that might have an allergic reaction. They might be having some kind of an allergic reaction where their airway is actually swelling. You're going to hear that almost musical whistling sound. And a lot of times, depending on the severity, you don't need your stethoscope to hear this. You can usually hear it from across the room. Next is rhonchi. So you can kind of hear it almost sounds like it's underwater. That's indicative of secretions or fluid or liquid of some kind in the airway. Next is stridor. That's a pretty nasty sounding one. This is upper airway narrowing, and one of the most common things you'll see is croup or epiglottitis in a child. This is that almost barking cough that they'll describe with a small child like that. Can be seen in adults too for a whole host of different reasons. And here's one with croup specifically.
Once you meet with a TurboTax
And another ad. I'm
expert
sorry
who will
about
do
that.
taxes for you, you're free to do not taxes.
Spectrum is bringing you seamless connectivity across all your devices with our best deal ever. Get Spectrum.
So if you look on the video here, you actually get a pretty good picture there of your glottic opening and your glottis there. That's that little flap we talked about earlier that can block the airway. In a child with croup, effectively there's swelling, which is what's causing these lung sounds. And that cough you heard is that very, very, very unique cough that you'll hear in a child with croup. I don't know what this one sounds like, but apparently this is what COVID lungs sound like. So those are some of the common lung sounds that you're going to hear out in the field when you're listening to a patient's lungs. Listening to a patient's lungs should be part of your assessment on every patient. You can uncover different things that you may not even expect to find just by listening to lungs. We covered a lot tonight about airway. We covered a lot of the structures. We covered a lot of the different disease processes. A lot of really important information that, again, will come back at the end, both in your registry exam, your practical exam, and your class finals, as well as obviously being one of the biggest parts of your patient assessment for every patient you're going to treat in the field. Make sure you read your book. Make sure you go through the whole book, go through everything there. The quiz is not open yet. Kevin should open that either tonight or maybe tomorrow. Those of you that had missing quizzes, make sure you get your quizzes finished up. And does anybody have any questions?
JT, is there anything we have to do for Sunday? Anything special?